wanted to just say a little bit more just about who I am, because I think it's important for this topic. So I'm a palliative care doc. That's kind of my day job and what I spend most of my time doing. I'm also a mom of 3. My kids are 8, 6, and 3, and to be honest, a lot of the communication skills training is really for talking to my kids. and I have a husband as well. So it's just kind of something that permeates a lot of what I do. And I think that's kind of how I connect to the work that I do. So talking about making good choices in tough times. So what I'll take you through, and the arc of today's session, we'll talk about palliative care, because really making good choices in tough times is the kind of bread and butter of what we do. I'm going to dispel some myths that are out there, talk about why it matters, and kind of what to talk about and when you're dealing with a serious illness. Okay, so palliative care, 40 years ago when the term first came into being, was really actually the same thing as hospice. And this is kind of its history. And the reason that term got coined, hospice back then, this is a picture of the first hospice ever in kind of modern times. This is St. Christopher's Hospice in London. And their care was really focused on the last stage of life. It was founded by Dame Cicely Saunders, and it was a place to go. And the term palliative care came from a French-Canadian surgeon, Balfour Mount, who said, that term doesn't make sense in French because it means an almshouse for the poor. So he came up with this other term, and that's how that term came into being. So it really was a synonym for hospice care. But today, palliative care is really a specialty that focuses on supporting patients with serious illness. And so we are partnered with and collaborate with patients and their providers in the Cancer Center and the Cardiovascular Institute, in the hospital, primary care. That's actually our academic home, is the Primary Care and Population Health division here, and throughout Stanford. And so this is really something that's become integrated and has really moved apart from hospice. So to dispel a couple myths, the first myth, have people ever seen this before? Palliative care is the same as hospice, right? So it's a really common one. And again, it has historical origins. So I think this is one that's very well and deep-seated. And the truth is that if you think about the arc of a serious illness, kind of between cure and hospice, and most of us live with serious illness somewhere in the in-between. Palliative care really spans that in terms of when that kind of care is appropriate. It's supporting the stress and addressing the symptoms of serious illness, and that can happen at any time. And so I want you to remember this as kind of the picture of palliative care. It's in that arc. In terms of whether it's different from hospice, it is really covering the gamut of when a patient has a serious illness. The next myth, palliative care means that I'm dying. And I think this is the other thing, that just the implications of those words, of this program, and of having kind of conversations about palliative care, that this is pretty scary. And so again, another myth. And so I wanted to read something from a patient with a serious illness. So Amy Berman is a patient who has stage 4 breast cancer, and she testified before the US Senate Special Committee on Aging about her experience and what she identified as major needs for healthcare and healthcare reform. And she spoke to basically patients and patients' families who have serious illness. And what she said was, perhaps the most important aspect of my care, the reason that I'm doing so well despite being seriously ill, is palliative care. Palliative care is the best friend of the seriously ill. It is an extra layer of support that goes along with the care provided by my oncologist. Studies have shown that when palliative care is added at the beginning of a serious illness, that people feel better and live longer. My palliative care provider has helped me determine what care to opt for and address my pain and symptoms. The team-based care also addresses the needs of the family, care coordination, and even spiritual needs. So that was really powerful coming from a patient. She's lived with stage 4 breast cancer for some years. She is now a senior program officer at the Hartford Foundation, really working in advocacy and policy work for patients with serious illness, and really looking at both patients and caregivers. Another example I wanted to share about kind of dispelling the dichotomy or the closeness of palliative care and dying. So a lot of the work we do for patients with serious illness is actually directed towards cure. So our service works really closely with the bone marrow transplant service. And bone marrow transplant, you're doing a transplant to get to cure, okay? You're getting rid of, usually it's a leukemia or a lymphoma. And now I'm probably simplifying this, but pretty much you're wiping out your bone marrow with toxic drugs and radiation to replace that bone marrow with healthy bone marrow. And the toxicity of those treatments is tremendous. And so our service comes alongside bone marrow transplant. They call us to help patients and their families get through that. It is, and I've seen things it's unimaginable to put your body through that, but you want to come out on the other side. And so that's what our service is there for us physicians, nurses, social workers, chaplaincy. And so that is really directed towards cure, and these patients are living with really tremendous side effects. Last myth. Palliative care is just a soft skill. And I bring this up, and it's kind of very alive for me because I have to take my recertification boards this fall. So I know that this is a multidisciplinary medical specialty. It requires specialty level training. And actually, the specialty came about officially in 2007 by the American Board of Medical Specialties. It was sponsored by 10 different medical boards, including surgery, internal medicine, family medicine, anesthesiology, OBGYN, pediatrics, to say that this is an important subspecialty, and that explicitly there needs to be specialty level training to be a palliative care clinician. And there's also now board certification for nurses, for social work for palliative care, chaplaincy for palliative care. And so it has really developed into a specialty level field. And you can't take the boards without doing that specialty level training. So what can palliative care do for me? So what's kind of in the secret sauce? What are we talking about? And this information actually comes out of several studies where the clinicians were observed in terms of their visits with patients and families. And what they found is what palliative care was focusing on in those visits was patients coping. And when I say coping, I mean, how are you doing day to day? What's life like? What symptoms, what's distracting you from living? And can we help address those things? And that also goes for the family too. Helping people with their coping, with their symptoms, with their quality of life, improves their quality of life, and improves their mood. The other thing that they found palliative care clinicians focus on in those visits is they address what matters most and use that to guide treatment decisions. That there's not always a straightforward answer with regards to treatment paths. Sometimes both paths, they look like they're going to work. Which one is the best fit for me? And that makes a huge difference. And then also thinking about how we communicate about what matters most, doing that in advance, so this concept of advanced care planning. So you're thinking and hoping for the best, we aim for that, and also have some plans for options A, B, and C happening too. And so that's what they found was happening in those clinical visits with palliative care teams. The other thing I wanted to highlight from these studies is that, in particular, what Amy Berman referred to, the study where patients live longer. So this was a study that came out of Harvard where they had looked at lung cancer patients when they were newly diagnosed at stage 4 and randomized these patients either to have early palliative care visits alongside their regular oncology care and compared to just their regular oncology care. And what they found, the things that weren't surprising, were that those patients who were getting early palliative care, they felt better, they had better quality of life, better mood. They also found that they used the hospital less, they were in the emergency room less, and they lived longer. And this kind of blew the minds of everybody when this study came out. And I think that what it did was really encouraged us and stimulated everyone to say, what's happening in those visits? How can we make care better for patients with serious illness? And what does this look like in real life? So this is actually taken from an article by a New York Times writer named Paula Spann. I don't know if anyone's read her writing. She writes a great series on the new old age, but she writes on science and health. And so she wrote an article about palliative care. This was just in 2016. And one of the families she interviewed was a family, the Chins. And Mrs. Chin was 84 years old. She had colon cancer. And she'd had a recurrence, and her oncologist had recommended palliative care, and her son has said, well, you know, we're just not there yet. And she'd been dealing with kind of nausea and vomiting and other symptoms at home. She was really fatigued, and her son was her kind of primary family caregiver. And that's really common, that most people have a family member who's caring for them. And so she had been starting on additional treatment for this recurrence. And after a few months, and two other physicians saying to them, you know, you should really think about getting palliative care because it seems like this has been really tough. How can we support you better? And so he did. And what he found was a relief. And what happened in that visit is that what they talked about were kind of all the things she was dealing with day to day. Palliative care talked about, listen to everything, the pain, the catheter, she had to have a urinary catheter, the vomiting, the tiredness. They had a social worker who came from that team that helped them coordinate care and work with their insurance, which, I mean, I think you kind of need a fellowship or PhD to work with insurance these days. And that was a huge lift for them to be able to have that support. And they also had access to nursing, basically nursing care where they could call in with questions about how Mrs. Chin was doing. And they really wish they'd had it earlier. She was still getting her treatment, you know, to aim for that recurrence and getting rid of that recurrence. And so this is what it's like in real life to have that program and that support. So going back to what can palliative care do for me, I'm going to transition now to talk a little bit more about kind of this idea of having discussions about what matters most, how that directs treatment decisions, and thinking about what choices to make, and thinking about communication. So talking about what matters most. Most of the time, actually, I think everyone who's had serious illness or that's touched them has had at some point have to hear serious news. And what that can do, it just upends your world, and it's a shock. And some of this is trying to figure out what we can do in the midst of that. So this is a little tongue-in-cheek, and for those in the back, this is a cartoon of Kermit the Frog, who was my companion growing up. And he's sitting across from his doctor, and his doctor's holding up an X-ray. And it's got an X-ray of the hand inside Kermit. And the doctor says, you know, have a seat, Kermit. What I'm about to tell you will come as a big shock. And so, again, kind of completely turning your world upside down. But I can imagine, and I know this is what it's like from my experience having serious illness, having a loved one diagnosed with a serious illness. And oftentimes, you know, processing and trying to figure out what to do next in action, there's a sense of no control. And it's an illusion of no control. And I say that because really there's ways to direct and have priorities made to give you control in the midst of serious illness. And so communication about what matters most is central to that. I show this picture, I saw this and I was like, wow, that's pretty striking. This is a horse tethered to a plastic lawn chair, right? And again, it's this illusion of feeling that you don't have control. Someone else has the reins. So thinking further about this, when we talk about having a conversation and talking about what matters most, I do not also want to give you an illusion that this is easy or this just rolls off the tongue. I actually think this is hard work. And it's a muscle that we don't usually exercise. We don't use very much, talking about what matters most. And so I actually am putting up some phrases. These aren't necessarily the perfect ones for you, but sometimes it's nice to have a first draft to go off of when we think about having hard conversations. So when it's your loved one, to think about, you know, as you think to the future, what is most important to you? And you wait for that response and ask, what else? there's often, and actually, there's always more than one thing. And oftentimes, without having the conversation, it's sometimes hard to know what those things are. What's keeping you up at night when someone has a serious illness? And it's a question that only that person can answer, right? And what else do you want me to know? Okay. This is just a start. But again, like having a first draft to go off of is really helpful when things are, this is kind of hard to say. So when I say muscle, and trying out a different muscle, I kind of want to try something here to explain this. So if everyone could take your hands and clasp them together, all right? So most people, you clasp them together and look at which thumb is on top. You look down. So for me, it's my left thumb, all right? So uncross your hands, cross them again with the other thumb on top. Right? Feels a little weird. You got those muscles, you don't use them that way, right? So it's a little awkward. And then one more, this always gets me. So cross your arms, you're folding your arms. You look down, for me, which forearm is on top? When I look down, it's my left. Okay, remember that? Shake them out, cross them again the other way. Really weird, right? Yeah. So it's that awkwardness, that feeling, right? Your muscles can do that. I believe everyone can have these kinds of conversations and say these words, but it's hard. It's going to feel awkward. And to kind of use a phrase that's out there in Silicon Valley, lean into the awkward. It's okay, and it's probably because you're doing that right. It's because it's hard work. And when it's you that has a serious illness, words you might say, I usually say, let's first start out saying, I'm doing blank, okay. I'm doing okay right now. I'm doing great right now. And I would say that the best times to have these conversations, if you can, is when things are going well, right? It's not crisis. It's not when you're hospitalized and actually your loved one actually isn't able to speak. Those are hard times to have conversations, right? Sometimes it's when you're in the car and you don't have to look directly at them. And so my friends who are parents of teenagers tell me that that's a good strategy to have conversations sometimes. But because these are hard words. Again, here are some important things to me as I look ahead to the future. My biggest fears and worries are, right? So these are some simple phrases, but I think, this is not something that I think is intuitive to figure out what are those priorities and how to use those to make sure that the decisions we make when we have a serious illness line up that way. And I think about serious illness often in the context of kind of being on rough waters. Sometimes it's very stormy, sometimes the water is just choppy. But when you talk about and have prioritized what's most important, you are raising the sails and you're directing your ship in the midst of that. So you don't want to spend the wind without raising the sails, okay? And this is kind of one of the analogies that I think about. And just talking about what matters most, so you know. And you don't want to leave anything on the table. Opportunities where you could direct care the right way based on what is important to you. So I want to talk about just two patients, two stories. And the first is Jack. And Jack was a patient I met in the ER. I got a call from the house staff, and it was this intern over the phone who said, oh my gosh, Dr. Harman, we have this patient, Jack wasn't his real name. He's coming in, he has multiple myeloma. And he has a lot of swelling, and he's gone through treatment. It's in his heart. He's having a really hard time. And he is angry. And I could hear the intern on the phone kind of cowering. It's like, oh, Dr. Harman, yeah, we talked to him about how things were, and that his time is limited. His time is on the range of months. And I was like, that's terrible. And so I go into the ER, and the Stanford ER, if you've been there, it is not the best place to have a conversation. So you're kind of like in these beds, these gurneys with curtains, and the ER staff are great, but you're kind of feeling like you're in a stall, and there's lots of chaos. And I sat down next to Jack, and in the midst of this, I could see he was upset. And Jack, he's a middle-aged man. He was in his 60s. I'm in my 40s. I think 60s is middle-aged now. That's right. And he looked at me, and he had so much life to live, and he was like, I am terribly upset. And I said, I'm so sorry to hear, just about the news you had. And, tell me more about kind of what's going on for you, what's going through your mind. And he's like, yeah, this is a bum rap that I don't have as much time as I had hoped. But I'm angry because no one ever talked about this with me. I would have made different decisions. He had just bought a house. And he said, I do this every day for my work. And I was like, wow. And then I was like, are you a palliative care doctor? And he's like, no, I'm a financial planner. I talk to my clients every day about what's most important, how they want to think about where they put their resources, right? I was like, wow. That has sat with me. I'll never forget that. And he told me, he's like, I feel that I've been robbed of the opportunity to do the planning I do with all my clients. He never had the conversation. And from there I said, that's also on us too, as a healthcare system, because he'd been a patient here. We need to change that. And I contrast that, so Tom is actually my father-in-law. So my first week of medical school, Tom was diagnosed with lung cancer. And I went to almost all of his appointments with his oncologist, his radiation oncologist. And for my in-laws and my husband's family, they had no medical folks. And so they were like, oh, you're in med school, so you should come and help us understand. And I was like, first-year med student is not that different than the person who's not in medicine. And so I learned so much from that, though, in terms of how to have conversations, because Tom and Sue, so my mother-in-law, really had certain things they held as important, as kind of guideposts. For them, one of them was their faith, are Christians, their family. So Mac, my husband, is actually an only son, only child, but spending time with family. Tom really didn't want to spend a lot of time in the hospital. He was running a company that was a steel wire manufacturing company, and that was important to him, to be able to make sure that company did okay. He had about 50 employees, and this was back in Cleveland. And so he went through multiple lines of chemotherapy. He had radiation. He ended up having brain radiation because it had spread to his brain. And that last summer, so this was just the summer before my second year of med school, his cancer had grown through the last kind of cycles of chemotherapy, and he had sat with his oncologist and said, I go to this place called Ajax Island up in Lake Huron in Georgian Bay. And I don't know if anyone had heard of this place? Probably not. Yeah, a couple of people. It's actually, yes. Yeah. And it's a really special place. But Tom said, I go up here. We have a cabin up there. I've gone up there every summer since I was age 3. His height is ticked off on the door frame. And my husband's, actually, since he was a child. And it's a special place. It's where I spend time with my family. And I also hear that chemotherapy, there's a next line that I could try and see what it would do. Will that get me there? Will I be able to go back there if I do this chemotherapy? Maybe the following summer if it's not this summer. And we talked about that because Tom knew that his cancer was serious. And so the oncologist said, hearing that, you should go. You should go this summer, and we'll see how you are when you come back, because that sounds really important to you. And so we went up there, and we were there for, I think it was like 4 or 5 weeks, and he came back, and he wasn't as strong, and so that was his last summer in Ajax Island, and he died later that fall in hospice at home. And throughout the course of his illness, he was never hospitalized. And he had a lot of very aggressive intensive therapy with the chemotherapy lines that he had. And so again, I just saw that as an example, and for me it was formative because I was in med school, but seeing that and the power that those priorities and being able to actually articulate them had, because he left this world knowing that he'd spent time with his family the way he wanted. And that was probably one of the most important learnings I had in medical school. So, for you all, I think about this wisdom, not necessarily because I'm wise, but wisdom for what I should do on Monday. WISDOM. Start a conversation. Start a conversation about what matters most now, maybe, or in the future with the serious illness. That may be with your loved one, and maybe with your doctor. And I'll pause there because, doctors, it's hard for us to have these conversations too. So there was actually a survey of doctors last year in the state of California, and they said these topics are really important. 99% of physicians who take care of patients with serious illness felt this was important to talk about what matters most. Half of them felt uncomfortable bringing it up. Only a third had had training. And folks who were more likely to talk about it had had training and worked in a system that made this a priority to direct someone's care. So have a conversation. And it might be with yourself. I say that too because I think this is also something that in the midst of the chaos and the stress of having a serious illness, sometimes it's hard to think about this for ourselves. Ask for a palliative care referral. So we see patients, all ages, all types of diseases, and you can ask for a palliative care referral just to meet us, or you're having things that are coming up, causing a lot of stress, a lot of symptoms, your loved one is, another good reason to see us. And then this website, www.getpalliativecare.org, is a website where it's a directory of all palliative care providers across the US. And you can also look up just information sheets about different illnesses and symptoms, palliative care resources. So it's a great website. It's for patients and families. Also here at Stanford, this is galvanizing us to say we want to build a center of excellence for palliative care. This is so important as we take care of patients with serious illness. We're looking at new models because a lot of care is happening outside of the hospital, outside of the clinic. Looking at training, exquisite training, and having these tough conversations. Right? When seeing that poll, that survey of clinicians having such a hard time, we need to act on that. And so this is something that's really important that we're developing as a new center here. And lastly, thank you. Thank you so much for being here, for listening. I know this is a hard topic. We actually have a booth in the Ask the Experts Pavilion on the lawn, and our team is there. I'll be there after this. So please come. We'll have brochures. We'll have basically handouts and kind of having conversations, a few giveaways. So come visit us. This is our team here at Stanford. Lots of us here now. We grew from 2.5 people to this in the last 10 years. And again, thank you. Oh, questions? Yes.
Hi, I'm having a little trouble understanding the definition. I think you went through you dispelled some myths, and I'm more of a bright line kind of a person.
Okay.
So I'm having a little trouble with the definition, and I'm okay with soft definitions. Yeah. But how does one know when to ask for palliative care? That is, what's a serious illness?
Yeah.
I mean, stubbing the toe, probably not.
Yeah.
But is diagnosis for type 2 diabetes, is that serious? It's probably not fatal. It might be in some cases. Does it have to involve a diagnosis of, let's say, a decent probability of fatality or something like that? I mean, what is it?
Not necessarily, and I think it's a really good question. I'm glad you brought that up. And I think, so to be honest, part of it is because the field is evolving, because it grew from just, this is just hospice to we need to think about this more as a different way of caring. And I would say that with serious illness, I think about it where you're right. So it's, if I think about stubbing the toe, definitely not. But I think about type 2 diabetes. I think when it becomes more uncertain about kind of how living with that diabetes is going to occur, sometimes type 2 diabetes leads to kidney disease, for example, heart disease. And when there's more uncertainty about, this is actually going to change the length of my life, what my quality of life is like. And that's when I start thinking about palliative care. Oftentimes early in diabetes type 2, you're doing some lifestyle changes, but it may not be that it's actually affecting your organs or your organ function. And palliative care, this definition about this extra layer of support, what Amy Berman talked about, it's a specialty team that's multidisciplinary, nurses, physicians, social workers, chaplains, that help basically address serious symptoms, treatment decisions, and the distress of having a serious illness. And when I say that, I talk about the family system, because sometimes it's because their caregivers are struggling and burning out. How can we support them better? And sometimes that, that primary clinic, the cardiologist clinic, the oncologist clinic may not have that team of resources to address this. Another service in terms of that we're starting to develop here is actually a pediatric guidance and support service for patients who are parents, and how to support parents who have a serious illness who are parenting through that. How to talk about having a serious illness with a child who's under age 18. And that's the kind of support. So I thank you for that question, the question about what does palliative care mean and what's a serious illness. And I think it does reflect some of the evolution of the field. But there's so much, I think, that we're not addressing for patients with serious illness.
Questions?
Yes.
Thank you for an excellent talk. I just wanted to follow up on the previous question, as well as a chart you showed and the point you made about palliative care being an arc from cure to hospice. I was wondering if that arc couldn't be stretched upstream even further, and you also talk about palliative care being a referral service. Wouldn't it be more ideal or better if palliative care could be integrated into a treatment plan for everybody with a chronic illness or a serious diagnosis?
Yes. So Mukun's question is about how, why wouldn't it be better if palliative care was just integrated into the routine care, the standard care of patients with serious illness? I absolutely agree. And we didn't have time to talk about this, but one of the challenges with a new field is that there's not a lot of us. And if we do the math, we're about at half the staffing in this country to be able to provide palliative care at that specialty level to every patient with serious illness and their family. And so we're recognizing that that model is not going to work quickly. And so what we're trying to do now in the field is to help train our frontline clinicians who take care of patients with serious illness, not palliative care specialists, but all the primary doctors out there, the primary clinicians, that's also nurses, social work, to do kind of that really basic level of palliative care, and then access the specialty level for some of the more complicated issues that come up. And that's our kind of interim strategy right now, but we are trying to look at integrating that. The American Society of Clinical Oncology has said for patients who are reaching, basically they've said at different stages we should think about palliative care routinely, right? So in getting into stage 3, stage 4 for different cancers. And they have proposed in their guidelines that it should be part of routine standard care. So a lot of these fields are recognizing that. So thank you. Yes?
So when you talk
Here you
about,
go.
Oh, sorry.
So when you're saying serious, and he mentioned chronic illnesses, so are you putting like Parkinson's disease or
Yes.
depression or addiction part of your serious, or is, because those are chronic?
Yeah, they are chronic, and I think the other thing is they certainly have massive impact on the quality of life of patients, and some of them often also on the kind of the lifespan, on prognosis too. But it's years, right? This is not something that's happening in months. We deal with that as well, but I think part of that is that you will, for patients, for early, think about it, Parkinson's, for example, that you may talk about advanced care planning, and you could see a palliative care specialist for that. We also want clinicians to be able to talk about that as part of routine care too, early on. And so, again, I think that's a great question, talking about chronic illness and serious illness. I think they are actually, that they're almost synonyms, really. So I think that point is well made. Yeah. Sorry, another question. Oh, yes.
Oh, well, I was a bit late in getting here, so I apologize
Oh,
if
that's
this has been asked before or if you addressed it. But I was wondering if you could talk about physician-assisted dying and Stanford's position on.
Sure. Yes. So the physician. So the question was about physician-assisted death and the recent law that was passed in 2016 called the End of Life Option Act, and Stanford's policy on that. So we, as an institution, have a policy that we participate. It's something that we participate in, meaning if one of our patients has requested that we have basically a process and structure for patients to be able to go through that process and get that prescription. And so it's relatively new, but as an institution, we're participating alongside many of the other larger academic institutions. It doesn't mean that it's an endorsement. It's that this is something that has become a legal kind of act and an option at the end of life, and that we are basically choosing as an institution not to opt out, but to say if our patients come and ask about that we can talk about it. We can talk about all the options, actually, and we'll support them. Other questions? Did that answer your question? Yes.
Actually, my understanding is that if a patient wants it, they cannot have it if hospitalized at Stanford.
So in the hospital, we can't actually, the whole process actually needs to take place with a primary doctor, and that usually is in the clinic setting. We don't actually give the medication on premise in the hospital. That part is correct, but it's not because we don't participate. It's just because of some of the basically policies and regulations about what our staff can do. And
a number of other hospitals do allow it, and I just wondered why Stanford was the exception.
Mm-hmm.
Thank you.
Yes. You had a nice. Oh, sorry. Wait, go ahead.
Can you give us some insight into the current state of reimbursement for, from insurance, various insurers for palliative care? And also, is there sort of a limit to how many sessions you can have? How do you address that?
Yeah. So most insurances now cover palliative care visits, and I think one of the things is that we're addressing things in our visits other than the primary diagnosis, and so that's kind of how at least palliative care as a field has been able to ensure that this is covered. I think Medicare, Medi-Cal, or state Medicaid program also have basically components to ensure coverage of palliative care. And actually, I think Medi-Cal is now has actually added an additional statute saying that this is something that they will ensure coverage of, because Medi-Cal was a population for us that we were having trouble getting reimbursement coverage. So, yes.
So you had a very nice diagram of all the different people on the palliative care team.
Yes.
And I was just wondering what your unique role as the physician is,
Sure.
as opposed to all the other physicians involved.
Yes. So, so as a palliative care physician, and so the question is kind of what's my role or the physician's role in palliative care compared to nursing, social work. So often what we're called to help with, actually the bread and butter of a lot of what we do is communication about what matters most and trying to figure out how to align really complicated medical plans with that. So it does have kind of some gathering and coordinating of medical information and to think about how to frame decisions and then into the context of a patient and family's values. That's probably the bulk of what we do as a physician. I think other things that are more unique to the physician role in palliative care are really complicated symptom management regimens with medications. So some of our primary providers are uncomfortable with medications like methadone or medications for hiccups, other things that are just not necessarily in the primary wheelhouse of the oncologist or the primary care doctor. And so we are often helping with that from a medical standpoint, understanding the physiology of those symptoms and trying to target those receptors, essentially. Does that make sense? Okay. Yes. I know you're waiting, so we'll go to you next. Oh. Sorry, it's being recorded, so we're trying to make sure we capture these questions.
Yeah, what are some of the options? How would you deal with, like, say, intense pain and discomfort and pharmaceutical treatments there?
Right, right. So, I mean, with intense pain, it's certainly, you know, everyone's heard of this, you know, opioids, right? So, but that's not the only option. Those are very effective for pain, certain types of pain, but pain is actually quite complex in terms of the source, whether it's nerve damage, whether it's actually just damage to the actual kind of tissue or muscle or bone. And those different types of pain require different types of medication. So there's specific medicines for nerves. You might have heard of things like trileptal or gabapentin, Lyrica, things like that. And then there's also, you know, anti-inflammatory agents if there's an inflammation component. So it's really about targeting what type of pain it is. And there's also interventional approaches. So our anesthesia colleagues who, you know, are really adept at putting needles into things and actually kind of targeting a particular nerve. You can have more targeted blocks that are it's a procedural approach. So, question? Yes.
When does palliative care? When and how does palliative care transfer into hospice care?
Into hospice. Okay, it's a great question. So the question was, when does palliative care transition into hospice care? So really that transition happens when a patient is at a stage where the disease-directed treatments, either they're not working, or they're not effective, or they're actually making the patient worse than the disease itself. And so that's a good trigger of saying, you know, this doesn't seem like the right fit. And then from there, when goals are focused, when the primary focus of care is on comfort and quality of life as first and foremost. The Medicare definition, and I want to mention this only because it does govern often a lot of what insurances will do or not do, is that there also needs to be a certification that the estimated prognosis is 6 months or less. You know, that it is not a hard and fast rule in the sense of sometimes you can have a trial of hospice. Some patients get better, and then they come off of hospice. Other times they're on hospice for a year or more. So the 6 months is something that I think is a little antiquated, but it came in 1983 when that first benefit, the benefit was first kind of made officially part of Medicare.